Good afternoon. Can you see? So, the next group of antibiotics, which are miscellaneous, only one important group is remaining, that is fluoroquinolones. Most of other groups we have completed. In this, what are various other antibiotics which are not that way classified under one or other name, and how they are working, we shall see it, and let us see the various things which are associated with this. So first, these are what? Clindamycin, linezolid as such we have seen. Metronidazole, it is actually anti-amoebic agent, but it has got very good activity against anaerobic microorganism. Nitrofurantoin, very old drug. Then this quinopristine and dalfopristin, then daptomycin, vancomycin, then cholestyramine. These are various drugs which are antibiotic, and it is not, they are not part of any big class or something, and they are individually they are very strong one, just like chloramphenicol we have seen earlier. So these are the agents which are having very good antibacterial spectrum and use. So first in that case is clindamycin. It is used for chronic bone infections. This is again unique with this. Then genitourinary infections, intra-abdominal infections, and other serious infections. But it may cause pseudomembranous colitis, that is the colon will have pseudomembrane like additional this one inflammation, and thus it is having this action. Then linezolid we have seen already. Linezolid, it is used to treat vancomycin resistance, Enterococcus faecum infection. So this is VRE, that is vancomycin resistant Enterococcus faecium. It is hospital acquired skin and skin structure infection. Particularly it is also useful in the case where it is MRSA, that is methicillin resistant Streptococcus aureus. In all cases it is used. It may cause hypotension. It can cause serotonin syndrome if taken with SSRIs, that is selective serotonin reuptake inhibitors, and it can cause some reactions if taken with tyramine containing food. Examples are chocolate or cheese. So in that it is present, so it should not be given. Linezolid has to, but linezolid is that way very common nowadays. It has become almost in almost prescription it is going, because it is a new drug, and many bacteria has not so far formed resistance against it, and it is widely used. Then metronidazole, as I told you, basically it is it was actually for a long time it has been used, prescribed for this protozoal infection, that is amoebiasis, and it is a very good drug. But it has been found that this drug is also having very good actions for anaerobic actions, particularly intra-abdominal and gynecological infection, particularly in female genitourinary tract infections, where females are very prone to this kind of infections. So they are very good one. Definitely they are actually, basically they are anti-protozoal agents, but it can cause several drug interaction. We shall see metronidazole separately when we shall see anti-protozoal drugs or anti-amoebic drug. At that time we shall see it typically. Then next is nitrofurantoin. It is primarily used for urinary tract infections which are caused because of E. coli, Staphylococcus aureus, Klebsiella, and Enterobacter. It has to be used carefully, particularly in case of where the renal function is impaired. The drug gets concentrated in urine. See, mind well, always remember one thing. This is how the application of logic is there. Even you should remember it. The drugs which should be good, which should be very good for urinary tract infection, they should be what? These drugs should be excreted through urine in unmetabolized form. So we have seen recently, yesterday also we have seen some of this, that these are excreted unchanged. So those drugs which are excreted unchanged through kidneys. There is no metabolism is there, the drug is active, and this active form is excreted through kidneys. That means it is available in active form in the kidneys, and these all drugs they can be good candidate for urinary tract infection if they are not causing any side effect or irritation or inflammation or injury to nephrons. So example of this nitrofurantoin, it is primarily used for urinary tract infections because it is not metabolized and it is excreted through urine. It should be used carefully in renal function is impaired. Drug concentrates in urine. It may cause fatal hepatotoxicity. The drug is usually well tolerated if the patient is kept well hydrated. So if good water amount is taken, then this drug will not cause much adverse effects, but it is reserved particularly in very typical cases where other drugs or safer drugs are not useful. Then next is quinupristin and dalfopristin. They are used in combination, that is 30% is quinupristin and 70% is dalfopristin. These are working synergistically. They are used for bacteria and infection. They are caused by vancomycin resistant enterobacterus coccus and other complicated skin infections. Then daptomycin, it is a new class of lipopeptide. It is used to treat complicated skin and soft tissue infections. Next is vancomycin. It is a natural bactericidal antibiotic. If you remember the previous one when we started with penicillin, in the classes it was vancomycin was one of the class, along with beta-lactam, linezolid and all, which are acting on cell wall. So this is natural antibiotic. It is bactericidal, so no semisynthetic. It destroyed cell wall. The treatment of choice in the methicillin resistant staph aureus and other gram-positive infections. The must monitor blood levels to ensure therapeutic levels and prevent toxicity. It may cause ototoxicity and nephrotoxicity. As so, because of all this, many people believe that it is somewhat similar to that of this streptomycin or aminoglycosides, but it is not the case. It is something separate, because aminoglycosides mode of action wise they are acting on protein synthesis, while these vancomycin is acting on the bactericidal and it is acting on cell wall. It destroys cell wall. It may cause ototoxicity, nephrotoxicity. It should be infused over 60 minutes. Rapid infusions may cause hypotension, that can be concern. The intravenous site should be closely monitored for the injury or thrombophlebitis. It can cause Redman syndrome, that is flushing, itching of head, neck, face, upper trunk. Antihistamine may be administered to reduce these effects. Again, here also adequate hydration has to be maintained, and if it is not contraindicated, if the hydration if contraindicated, then cannot be used. Otherwise, it should be done. Monitor the trough levels carefully. Now, what do you mean by trough levels? If you have studied by pharmacokinetics, then every drug at the time of administration it achieves some peak and then it comes down. So the lowest value in the pharmacokinetic graph, viability graph, when we are going for continuous administration one after another, so when we are administering it, then whatsoever the lowest time it is coming, that is called as a trough levels. So trough levels should be monitored carefully. It should not become toxic. It should not be less than the effective dose. So that has to be made this everything we'll learn in a topic in 5th year. That is what we call it as a therapeutic drug monitoring, where there are some such drugs which are very important. Their concentration has to be monitored. So this is one of the drugs where trough concentration has to be monitored. It is essential to obtain cultures from appropriate sites before beginning. We have already seen it. Instruct patient to take antibiotic exactly as prescribed. Yes. So these are the drugs which are different than or which are not usual one. Let us go for other drugs then. So next class of drugs are quinolone and fluoroquinolones. These are again very important class of drugs. These are having actions on the DNA, and it is a very big group of compounds. So let us see what kind of things are there. So this is structure, and these are called as quinolones and fluoroquinolones. They are the family of broad spectrum synthetic antimicrobial agents. The parent of the group was nalidixic acid, which was introduced in 1962, and then nalidixic acid was quinolone, and then later fluoro group was inserted, and it has got a fluoro group attached to the central ring system, and therefore we call them as a fluoroquinolones. We have got classifications of this, that is, first generation was nalidixic acid and cynoxacin. Cynoxacin is now removed from the clinical use because of the adverse effect, and other good agents are available. Second generation, which was again very common in second generation, the first one was actually norfloxacin. Then after that the other other agents came, that is, after norfloxacin came ciprofloxacin, which is still available and still been marketed. Then enoxacin, then ofloxacin. These were the second generation floxacins. Third generation was levofloxacin, greyfloxacin, sparfloxacin. Then fourth generation is moxifloxacin, provafloxacin. So these are various. Apart from that, there are many other floxacins are marketed, like gatifloxacin. Then still few more are there. So all these are there. These are widely used. Again, just like in penicillins we have seen generations, or in cephalosporin we have seen generation. Here too there are various generation, first, second, third generation are there. We have seen the impact during generation, that every generation wise what happens is there is a improvement in the spectrum and decrease in the resistance. Means most probably the previous one was having resistance. Here it is comparatively less resistance and better spectrum or higher spectrum. So these are there. They are both are actually these quinolones, fluoroquinolones. They are bactericidal in nature. They enter into the host cells, and therefore they are active against intracellular pathogens like Legionella, Mycoplasma, and Chlamydia species, because they can enter inside the cell. What is the mechanism of action? The fluoroquinolones, they work by inhibiting one or more group enzyme, that is called as a topoisomerase enzymes, which are needed for supercoiling, replication, and separation of cellular bacteria. I repeat, I told you these are the group of enzymes. In that, one enzyme is known as a DNA gyrase. It is a topoisomerase 2 that is catalyzing the negative supercoiling of the circular DNA found in the bacteria. So this is how, if you remember, we have seen during genetics that whatsoever specific portion of the DNA which is has to be expressed either during replication or during transcription. So that much portion has to be, because most of the portion are wound on the nucleosomes. So from that it should come, and nucleosomes and then chromosome, that becomes a very coiled and supercoiled structure. So first are coiled, they are rotated, DNA itself is rotated, then twisted. This twisted DNA is wound, or it is surrounded to nucleosomes, or it is surrounded to histone molecules. Okay, and this, that is, we call it as a beads to string, if you remember. And these bead to strings, they are again coiled. Again they are coiled in a such a way that the next is fold is there, and this is the technique of compression or super compression. We have seen that very big or very lengthy DNA is compressed in very small cell, particularly even rather nucleus of the small cell of microorganism or human cell. This is how these things are done. So here this DNA gyrase is a topoisomerase 2 enzyme that catalyzes the negative supercoiling of the circular DNA which is found in the bacteria, which cannot, if this is inhibited, then this negative supercoiling cannot be done, and this will not allow the proper arrangement of DNA or compression again. The topoisomerase 4 is involved in the relaxation of supercoiled circular DNA, and it enables the separation of interlinked daughter chromosomes that at the end of the bacterial DNA replication. So when these two are inhibited, then the negative supercoiling will not be possible, because whatsoever DNA which is used for expression, that DNA cannot be repacked again, it cannot be compressed again nicely is one thing, and therefore there will be chances of its injury more, and topoisomerase 4 will be involved in the relaxation of this supercoiled DNA. It will cause relaxation of it. It will enabling the separation of interlinked daughter chromosomes, but if it is inhibition, then these interlinked daughter chromosomes cannot be separated, and thus it will affect replication. So thus it is affecting replication, protein synthesis, and because of that they are very, very effective. So these are the drugs which are acting. There is a schematic representation. See, this is how histone molecules are there, and around which the winding is taking place. So this is the job of DNA gyrages, so that they will be winding up DNA which is there, and topoisomerase 2 is there. They are causing this separation of the daughter DNAs for replication. So this will be there. It will fluoro will bind quinoline to these two nuclear enzymes, and they will thus inhibit the DNA replications. So this is the basic mechanism these are having, and because of that they are very effective agents. These are acting on gram positive, gram negative. As such, both are the targets, but in gram negative, primary target is gram DNA gyrase enzyme, while in case of gram positive bacteria, the primary target is topoisomerase 4 enzyme. Antimicrobial spectra, as we have seen, they are broad spectrum because they are active against gram negative, gram positive, and even other microorganisms. So as such, they are well absorbed after oral administration. Absorption will be decreased with sucralfate or antacids which are containing aluminum, magnesium, or dietary supplements containing iron or zinc. So fluoroquinolone should be given 2 hours before or 4 hours after these preparations. Norfloxacin is only 30 to 75% absorbed, and others are having bioavailability of 80 to 90%. Now one more important thing, the drug which are having less absorption from GIT. So what can be their consequences if the drug is less absorbed? That means the drug will remain in the GIT. It will reach to colon. So those drugs which are not completely absorbed, then they have more chances of having the destruction of microbial flora, okay, the colon bacteria. And the second important thing is they are very effective, or they are very good drugs in the cases of the diarrhea or dysentery because of the bacterial origin. So bacteria or whatsoever like Salmonella, Shigella, these are various bacteria, E. coli, they are responsible for bacterial dysenteries. So in that cases, these drugs which can remain in GI tract, or which are coming back, which are available in GI tract, they are very good drugs for the local effect by given oral route. So these are norfloxacin is only 35 to 70% absorbed. Others are bioavailability of 80 to 98%. Ciprofloxacin, levofloxacin, ofloxacin also available for intravenous use in addition to oral use. They are distributed widely in body tissues and fluid. Their concentration in prostate tissue, kidneys, neutrophils and macrophages, lung that exceeds the serum concentration, means they are selectively taken in these tissues. They reach in a high level in bone, so they can be useful in various bone infection. Penetration into CSF is poor, except ofloxacin, which is 90% of the serum level, it is going to cerebrospinal fluid. TF is variable, that is, it can be from 3 hours to 10 hours. So accordingly, twice a day or thrice a day or once a day can be administered. Elimination mostly by kidneys via active tubular secretion. It can be blocked by probenecid. This is again we call it as under favorable drug-drug interaction. Similar you might have seen with penicillin and probenecid. Here also same thing is there. If probenecid is given, wherever there is a tubular secretion, probenecid will be competing with it. It will get excreted first, and thus it will not allow to other drugs to get excreted. Dosage adjustment in renal dysfunction, except for moxifloxacin, which is eliminated non-renally. It is partly by hepatic metabolism and partly by biliary excretion. Now the drug which are again absorbed completely and excreted in biliary excretion, they can also be good choice in GIT infection, because the drug is actively in active form it excreted into GIT. Gemifloxacin partly renal and partly non-renal, and it is important in means this point has to be kept in mind in the renal insufficiency in the patient which are having renal problem. In this patient, this care has to be taken. So let us see what are how we can compare about their spectrums in various groups. That is, so first generation are there. These are nowadays not used because there are only two are remain. Out of that, one has got adverse effects. Only nalidixic acid is there. So they are not used much. They have moderate gram-negative activity. They achieve minimal serum concentration and are restricted to the treatment of uncomplicated urinary tract infection. Example is nalidixic acid. The second generations are which are still used. I told you norfloxacin, ciprofloxacin, ofloxacin, etc. So these are the second generation. They have expanded gram-negative activity and also have gram-positive activity, and a typical organism like mycoplasma or chlamydia. So if you will see that they have more action comparatively against gram-negative and some action against gram-positive. Then next is fourth generation fluoroquinolone. They show improved gram-positive coverage, maintains the gram-negative activity and gains anaerobic coverage. So in addition to gram-negative, gram-positive, they are also acting against various anaerobic organisms. So this is how they are having comparatively more spectrum and more effective treatment of antimicrobial agents as compared to previous generation. Now if you see one by one, so first one was nalidixic acid. It was active against gram-negative bacteria like E. coli, Proteus vulgaris, Klebsiella, Shigella itself, and no activity against Pseudomonas aeruginosa. Ciprofloxacin has got gram-negative like this aeruginosa, then gram-positive like Staphylococcus species. It is active. It has no activity against Streptococcus pneumonia, and it was active against atypical bacteria. Then next came as a levofloxacin, that is the third generation one. So they are acting on mostly gram-negative, most of the gram-negative microorganisms. In gram-positive, there was improved activity against Streptococcus pneumonia, and atypical bacteria, they have improved activity against Mycoplasma species, Chlamydia species. And lastly, fourth generation is a moxifloxacin, again very good activity against most of the gram-negative activity drugs. They have gram-positive activity including Streptococcus pneumonia and anti-anaerobic activity. So these are therefore extended spectrum, we can say, or the spectrum is extended. Now what are the clinical uses, or how these fluoroquinolones are used in clinical setting up? So first one is nalidixic acid, well absorbed from GIT, partially metabolized in the liver. It shows poor tissue penetration and low plasma levels. It cannot be used for the treatment of systemic infection. It is excreted in urine, and it is available in very high amount in the urine. Now it is the another one is norfloxacin is effective against gram-positive negative organism in treating complicated and uncomplicated urinary tract infection and prostatitis, bacterial gastroenteritis which is caused by E. coli or Proteus or Klebsiella, Shigella. In that, norfloxacin effective. Ciprofloxacin is the most potent of this fluorochlorination for Plasmodium, P. aeruginosa, Pneumocystis aeruginosa, long post-antibiotic effect, well absorbed from GIT. Administration, either it can be given orally or intravenously, it is excreted in urine, but it is potent CY450 inhibitor, and because of that it can cause inhibition of many microorganisms, it can cause many inhibition of many drugs which are there, many drugs which are metabolized through cytochrome P450 metabolism. This drug can have big impact on this. Then next is ciprofloxacin. Clinically it is used in various urinary tract infection. It is used in intra-abdominal infections like peritonitis, bacterial gastroenteritis, sepsis, skin and soft tissue. Typhoid, ciprofloxacin is the first choice. If you remember, we have discussed during chloramphenicol that once upon a time, not very long back, almost 10 to 15 years back, chloramphenicol was the drug of choice for typhoid fever, Salmonella typhi, but nowadays ciprofloxacin is the first choice in the typhoid fever. It is also used in tuberculosis in some cases where there is a multi-drug resistant tuberculosis. It is used. It is treatment of choice in gonorrhea. It is treatment of choice in conjunctivitis. So there are so many effects or impacts or benefits this drug is having. Now, how the resistance is there? What is the other activities? So ciprofloxacin is effective in treating infection which are unresponsive to beta-lactam antibiotics, including ampicillin. It is not the drug of first choice for pneumonia or sinusitis because of the fluorochlorin have only weak activity against Streptococcus pneumonia, which is a common causative agent. Then these are effective against anthrax like agents, which is Bacillus anthracis, and drug of choice for post-exposure prophylaxis and treatment of anthrax. Alternate agents include doxycycline. Ciprofloxacin is equally active in infection due to penicillinase producing and non-penicillinase producing bacteria like Neisseria gonorrhoeae. Then important is they are active against various species like Enterobacter species, Escherichia coli, Klebsiella, Proteella, Serratia, Macrosens, Shigella species, which are prone for or which are responsible for various kind of infections. They are useful in GI tract infection, in acute diarrheal illness due to enteric pathogen like Shigella, as I told you, E. coli. These are the enteric pathogens. Clinical resolution occurs in over 90% of the patients. So that means it is very effective. 90% remission is. Then urinary tract infection, ciprofloxacin, norfloxacin are effective in treatment of uncomplicated and complicated urinary tract infections. Clinical and bacteriological response is similar to that of sulfamethoxazole and trimethoprim. So these are the advantages, these are the benefits or very good indications these agents are having. Then next is the levofloxacin. It is an isomer of ofloxacin and it has got a largely replaced it clinically. Very well absorbed from GIT. Administration either orally or by intravenous route. It is excreted unchanged. It has got long post-antibiotic effects, long acting, that is as once a day dose is sufficient. It is mostly used for treatment of respiratory tract infection due to Streptococcus pneumoniae, in pneumonia or COPD exacerbations. It is used in the treatment of prostatitis, that is prostate gland inflammation due to E. coli and of sexually transmitted diseases with exception of syphilis. It is used an alternative in the patient with gonorrhea. Additionally, it is due to its broad spectrum activities. The levofloxacin is utilized in the wide range of infection, including skin infection, acute sinusitis, nosocomial pneumonia, etc. So it is very important in most of the treatment. Then next is moxifloxacin, long-acting drug, single daily use, only once a day. The drug is to be administered. It has showing long-acting post-antibiotic effect. That is, once the administration stop, even after stopping administration, then the effect on this microbial agent will for long period of time. It is mostly used for the treatment of respiratory tract infection like pneumonia, COPD exacerbation, used for the treatment of severe bacterial infection including sepsis, peritonitis, and most potent fluoroquinolones against Mycobacterium tuberculosis. So this is again additional spectra that we can call that the drug is active against Mycobacterium species. It has got poor activity against this P. aeruginosa microorganism. So that way these are the very active, very having wide spectrum and very effective drugs still in practice or being practiced. Now, how resistance to fluoroquinolones is developed? So there are various mechanisms. One is important is there is a decrease in the permeability, because for action drug has to get inserted to nucleus, means from cell membrane first, and from cytoplasm it has to reach to nucleus, where in nucleus it will be acting on these various important enzymes like DNA gyrase or topoisomerases. So for that it must have to cross both the membranes, that is cell membrane and the nuclear membrane. So most of time if they are water soluble and no other way, then they are actively taken up by the bacterial cells. So this active transport is modified. It will be decrease the permeability to these drugs, and thus the drug will not able to enter inside the cell. Then next is most of the microorganism can initiate of the pump of efflux, that is they will form the channels in between, and from channels it will cause removal of this antibiotic, and because of this removal of antibiotic its concentration in the cell will decrease. Then there can be mutation of the enzymes, so that these enzymes will be mutated, and because of this mutation this drug will not able to bind to the various enzymes like topoisomerase or DNA gyrase, and therefore it won't able to show the action. Adverse effects which are prominent are abnormalities of bone and cartilage formations. Bone cartilage damage is in the weight bearing joints in the animal studies. Then it causes photosensitivity, and you can see the skin allergy. It is so when the drug was treated or the patient were treated with this drug, and along with systemic circulation it reaches to skin, and when their light falls on that, that will cause the metabolite formation, which can be dangerous. So this is called as a photosensitivity. Then next is tendonitis or tendon rupture. In few cases of rupture of the shoulder, hand and Achilles tendon have been reported. In CNS it causes confusion, insomnia, fatigue and depression, somnolence, etc. So it will cause QT prolongation. Now from this drug interaction onwards we shall see next time. Which is complete drug interaction rather. Drug interactions wise, it has got drug interaction with theophylline, warfarin, cyclosporine, etc. because this is the potent cytochrome P450 inhibitor. it increases the plasma concentration, and therefore toxic effects of anticoagulants, digoxin, theophylline, etc. So because of this, it will not allow the metabolism to happen as it is there, and because of that, drug will be slowly excreted. So these are the effects they are having. They are affected by this in the liver, that is by cytochrome P450 mediated actions. Other drug interactions, this fluoroquinolones in combination with the class 1A and class 3 antiarrhythmic agents, they prolong QT interval and may cause arrhythmias. So they are arrhythmogenic, we call these drugs are arrhythmogenic in nature. Then next is with other antibiotic, they have no synergistic effects with other antibiotic classes, and a synergistic inhibitory effect of fluoroquinolones has been observed on the binding of the neurotransmitter of the GABA. So this is only the synergism, but there is no benefit of combination, it is there. Then what are the antacids? A concomitant oral administration of magnesium aluminum containing antacid has been found to result the 6 to 10-fold decrease in the absorption of the oral quinolones. Sucralfate is an anti-ulcer antacid drug, and it has documented that substantial reduction in the quinolone viability when it is administered concomitantly with sucralfate. So here we finish the major drug interactions. Then we will go for contraindication and the further whatsoever aspects are there with the fluoroquinolones that we shall be studying in our next class. I hope you are understanding this. If you have any difficulty, we can discuss it. So take care, be careful.